Please, guys, very quick, straight to the point. Okay, guys?
So thank you for this kind invitation. I'm honored to be here. It was an outstanding day, and it's a true honor for me to present our trials in the field of prostate cancer. These are my conflicts of interest, and these are all the ongoing trials we have. And as you can see, we have 23 ongoing prospective trials. 8 of them are spontaneous trials, so they are investigator-driven, while we have 15 industry-sponsored studies. And we start with diagnosis. These are the unmet need of prostate cancer diagnosis, where we have to enhance the positive predictive value of multiparametric MRI and to optimize the diagnostic pathway based on MRI and MRI-targeted biopsy. To do so, we designed a trial to assess the role of a fully hybrid 18F PSMA PET MRI as a one-stop approach for the diagnosis of prostate cancer. We aim at enrolling approximately 160 patients with a suspicion of prostate cancer, of clinically significant prostate cancer. All patients will receive, at the time of MRI, a concomitant 18F PSMA PET, and all patients will receive a prostate biopsy, and we aim at assessing the added value of a PSMA PET at the time of MRI in patients who are candidate for a prostate biopsy. Another issue is to improve the reproducibility of a prostate MRI, and to do so we are assessing the role of artificial intelligence, and this is a trial aimed at evaluating the role of quantitative prostate in terms of improving the ability to identify clinically significant prostate cancer. We performed the preliminary analysis based on 115 patients, and you can see that the quantitative prostate is able to improve the accuracy of an inexperienced reader compared to experienced readers. So probably the role of quantitative prostate could be to shorten the learning curve of radiologists in evaluating prostate MRIs. We are also part of a large consortium aimed at assessing the role of biparametric MRI compared to multiparametric MRI. This is a study which is a multi-institutional study. We were able to provide more than 50 patients, and you can see the enrollment rate, and the results will be published soon. When we talk about staging, our main goal is to reduce the number of lymphadenectomies we still perform and to improve our ability to identify metastatic lymph nodes. And we should acknowledge that up to 80% of lymphadenectomies we perform currently are useless, are performed in patients who are PN0 at the final pathology report, and we have issues related to costs, related to increased and prolonged operative time, and increased risk of complications. So this is a study which is aimed at assessing the role of radio-guided surgery, which means the preoperative injection of 99M technetium PSMA and the use of a dedicated drop-in gamma probe to identify positive nodes during a surgery. We enrolled 60 patients, and we have a preliminary results on 34 patients who underwent surgery, and you can see that the accuracy is as high as 90%. We also designed and submitted this proposal for a trial aimed at assessing the role of a fluorescence-guided surgery, and this trial actually is aimed at assessing the role of a combined approach based both on fluorescence and technetium PSMA radio-guided surgery, and this trial will assess the role of this new combined approach in the identification of lymph node invasion and metastatic lymph nodes during a radical prostatectomy with concomitant pelvic lymph node excision. When we talk about active surveillance in prostate cancer patients, our main aim is to reduce the number of prostate biopsies performed during follow-up, and there are tools developed by our colleagues radiologists that aimed at standardizing the report of MRIs in the follow-up of active surveillance patients, and this is a multi-institutional validation of a precise score, and we will be able to validate this score in patients follow-up for active surveillance and to assess whether the number of biopsies in the follow-up can be reduced based on the precise score. We have trials, phase 1 trials and phase 2 trials in the neoadjuvant setting aimed at assessing the role of IL-15 in prostate cancer patients treated with radical prostatectomy, and pembrolizumab, and this is a trial which I presented also last year. We actually slightly modified based on IFAR request the trial design, and hopefully enrollment will start soon. When we talk about biochemical recurrence, we have heard the outstanding presentations this morning regarding the EMBARK trial, and actually we are working on a trial aimed at assessing the role of a new compound which is basically aimed at assessing the immunotherapeutic agents in patients with biochemical recurrence after radical prostatectomy or radiotherapy for prostate cancer. And this is a phase 1 trial which is ongoing in Spain, and we will be involved in the phase 2 trial. We also have a trial which is aimed at assessing the role of apalutamide in patients who experience biochemical recurrence after radical prostatectomy or radiotherapy, and these patients basically are submitted to a PSMA PET, and if the PET is positive, patients are randomized to radiotherapy plus ADT versus radiotherapy plus ADT plus apalutamide. And we also have a concomitant trial aimed at assessing the role of apalutamide in the primordium trial, as you can see here. So the aim is to assess the role of novel ADT and novel compounds in patients with a positive PSMA PET combined with concomitant image-guided radiotherapy. And the outcome here is defined by progression identified at PSMA PET CT. These are the ongoing trials in the metastatic hormone-sensitive prostate cancer and castration-resistant prostate cancer. And as you can see, we are testing several compounds in different settings. We have trials aimed at assessing the role of niraparib, darolutamide, and other novel compounds, pembrolizumab as well, in the Keynote 365, and hopefully results will be presented soon and will change the outcomes and the natural history of the disease in patients who experience progression after treatment and who are in a castration-resistant state or in a metastatic hormone-sensitive state. Thank you for your attention, and thank you.
Thank you, Giorgio.
Okay, thank you, Andrea, for this kind of invitation. I want to have a brief update on clinical trial in urothelial carcinoma. This is my disclosures. So the agenda, let's start with non-muscle invasive bladder cancer, muscle invasive bladder cancer, and then finally metastatic disease. So in non-muscle invasive bladder cancer, we have the timeline of BCG unresponsive disease. As you can see, until the 2020, with approval of Pembro in CIS BCG refractory disease, we have after several compounds that have received the FDA granted approval. In this table, you can see that in the last 3 years, the strategy is organ-sparing approach after the failure of BCG, with different responses rate, different timing to first evaluation. So this is a very, very exciting moment. So let's move to our clinical trial. This is a Sunrise clinical trial in BCG refractory disease, only in CIS with or without papillary disease. As you can see, after the results presented at AUA this year, we have only the cohort 2 enrolling patient with TAR-200 alone with complete response rate as primary endpoint. Let's move to the Sunrise 3 clinical trial. This is a phase 3 clinical trial in BCG-naive high-risk non-muscle invasive disease with CIS alone or in combination with papillary disease. We have three groups. The group A with combination of TAR-200 plus cetuximab versus BCG alone or TAR-200 alone. The primary endpoint of this study is the event-free survival. This is the last new opened clinical trial this year, the 057. This is a phase 2 clinical trial. The cohort is the cohort C after the completion of cohort A and cohort B. This is for BCG unresponsive disease with or without CIS and papillary disease. There is a randomization 1-to-1 to receive in the arm 1 pembro plus vidostolimab, that is an anti-TIGIT monoclonal antibody, versus the combination of pembro and favezelimab, that is an anti-LAG3 monoclonal antibody. Once again, the complete response rate is the primary endpoint of this clinical trial. Let's move to the muscle-invasive disease. This is the background. We know that nowadays neoadjuvant cisplatin-based chemo is the standard of care of treatment. Adjuvant nivo improves disease-free survival and hopefully overall survival in high-risk residual muscle-invasive disease. We know that neoadjuvant IO is very, very interesting, but we still don't have predictive biomarkers in this setting. So let's focus our attention to our patient. We have a muscle-invasive disease. We have to decide if to perform a bladder preservation or if our patient is a radical cystectomy candidate. So in this case, if the patient is cis-eligible, we have to perform an adjuvant chemo and then to plan a radical cystectomy. In this setting, we have the Keynote B15, that is a clinical trial. But if the patient is cis-ineligible or refuse the chemotherapy, we can offer at Raffaele Hospital 6 clinical trials. After the radical cystectomy, only in selected patients we have to offer adjuvant chemo or adjuvant nivolumab, especially in patients with high-risk disease, so residual disease. Unfortunately, in Italy, we don't have the refund for nivolumab, adjuvant nivolumab, so we have to include our patient in INVIGOR 011, a clinical trial with the ctDNA monitoring. So let's focus on the new two sponsored clinical trials. This is the Sunrise 4 clinical trials. It's a phase 2 trial to refer to cisplatin-eligible or refusal patients. They were randomized to receive cetuximab alone or in combination with TAR-200 before radical cystectomy as primary endpoint, the PAT complete response. This is the Neo-Godfather phase 2 trial. Once again, cisplatin-eligible patient or refusal. They were randomized to receive nivolumab plus placebo or with visoglutamab, that is an anti-GDF15 monoclonal antibody, before radical cystectomy. Once again, PAT complete response as primary endpoint and radiological response rate according to RECIST criteria. Let's move to the academic clinical trials, SURE-01 and SURE-02. Antonio presented a few months ago the preliminary results of SURE-01. This is the treatment with the sacituzumab govitecan 4 cycles before radical cystectomy and then standard of care. And the SURE-02 clinical trial is the combination with pembro plus sacituzumab before radical cystectomy and then 12 months of adjuvant pembro. So let's focus on the bladder preservation setting. We have to decide with the patient if to offer the 3-modality treatment, so radiotherapy plus something else, or an organ-sparing approach. We also have 4 clinical trials, new clinical trials in this setting. Let's focus on the academic clinical trials. This is the EUREKA clinical trial. It's for patients that are expressing HER2, at least 2+ as immunohistochemistry score. They receive adjuvant trastuzumab deruxtecan before be allocated to patient preference to cohort A, radical cystectomy followed by the standard of care, or another TURBT for 1 year. This is the second clinical trials, the NITO trials. This is an administration of an oral anti-PD-L1 small molecule for up to 12 weeks, and then another TURBT and then assessing, for example, for the complete response rate, we have to focus on an adjuvant treatment up to 12 months. In case of relapse of low-grade disease, we can discuss with the patient to have another treatment until 12 months or physician choice, or if we have a relapse of high risk, we have to perform the radical cystectomy alone or chemo radiation treatment. So, finally, the metastatic disease. Once again, the background, cisgem and dose-dense VAC were the standard of care at first line. Avelumab maintenance in responders is the actual standard of care, especially with the elevated overall survival in PD-L1 positive patients. And now we have the new standard of care, that is pembro plus enfortumab, presented at ESMO by Tom Pauls. This is the first line treatment that we have for very unfit patient, chemo and CPI naive patient, not eligible for any platinum-containing regimens. So they were randomized to receive atezolizumab as control arm, and then a bispecific antigen with anti-PD-1 and anti-LAG3, or the combination of this agent plus tiragolumab, that is an anti-TIGIT agent. Very quickly, for the maintenance intensification treatment, the Javelin bladder medley, we have patient responding or at least with stable disease after chemotherapy. The patients were allocated to the control arm, avelumab versus avelumab plus sacituzumab versus avelumab plus an anti-TIGIT1 and avelumab plus NKTR255, that is a recombinant human interleukin-15. This is a combination, a multi-group trial with exploring the activity of sacituzumab govitecan, either in first line or refractory disease. Very, very quickly. And then this is the Tropion, the last new clinical trials, the Tropion pan-tumor, all three clinical trials referred to first line, cisplatin eligible patient and untreated, and the second line or more. This is a treatment with datopotamab, an anti-TROP2 ADC, with a bispecific anti-PD-1 and anti-CTLA-4, or in the cohort B, the datopotamab plus an anti-PD-1 and anti-TIGIT bispecific. Once again, the primary endpoint is the primary endpoint. So, what's next? These are the data with very impressive improvement of overall and progression-free survival presented at ASCO, pembro enfortumab versus chemotherapy, with success in all pre-specified subgroups, but we have new open question. For example, what is the best second-line treatment in terms of sequence? When to stop treatment or to perform an ADC, the intensification in responders, how to intensify in non-responders, what is the best duration of the treatment, what is the rationale for combination of immunocheckpoint inhibitor and ADC, what is the best payload, and what about the combination of ADC, are they possible, safe? So this is an idea for a new concept study. Probably in the next few months, this will be the next first-line treatment, EV plus pembro. Then, when the patients are progressing, we have to do a second-line induction treatment with chemo, so carbocisplatin based on Gasky criteria. And then, based on the response rate and the stable of disease, we can randomize patients to receive a new maintenance phase. For example, the treatment with avelumab, so a sort of maintenance and immune checkpoint inhibitor rechallenge. We can use another ADC, so ADC post-ADC, sacituzumab govitecan, the combination of both, or placebo as a control arm. We also can assess, for example, ctDNA. We can do a ctDNA assessment before and after the chemo, and then, for example, during the maintenance phase, at disease progression or complete response for at least 6 months. So, this is my last slide. Nowadays, these are the phase 1, 2, 3 trials in urothelial landscape, from non-muscle invasive to metastatic disease, also sponsored to academic trials. Thank you very much for your attention.
Thank you. I got your question. So the criteria to select patients for trials, I mean.
I was saying this is such an impressive portfolio I've ever seen across all GU cancers for every stage of disease with multiple novel therapies. Now, besides your visionary leadership, like what is the secret recipe that allows you to open so many trials? Because we have a lot of challenges with our regulatory, clinical personnel.
The secret is out there. Secret is, first of all, to have a budget. The only secret is to have budget. Provided that you have budget, you have to pay contracts and to look first at establishing the trial machinery, which is much more important, I'm sorry to say. Somehow in clinical trial setting, even more important than doctors. It is much more important to have 2 study coordinators than 1 doctor if you deal with clinical trials. But if you deal with clinical trials, you cannot do clinical trials without a trial machinery on your shoulder. It's impossible, simply impossible. So the ideal proportion would be 1 study coordinator per 5 trials. This is the ideal situation, very ideal, almost impossible, but you have to take care of it, to establish a trial machinery composed by study coordinators, research nurses, and then, of course, smart doctors, and then you are structured enough to start trials. Otherwise, it's just a futile attempt of running besides trials or trying to open in trials that you will never open in your center. A lot of time-consuming issues, a lot of bureaucracy without by losing time and without resulting in anything. You should first have people and the right clinical operation team to establish prior to establish and to open studies.
Okay, so I'm gonna present you quickly the ongoing and in future activation trials in renal cell carcinoma. Okay, I'm gonna start with the adjuvant phase in clear cell renal cell carcinoma. As was previously presented, based on the Keynote 564 data, the major regulatory agencies approved pembrolizumab as adjuvant treatment in patients with intermediate high risk of recurrence, or defined as M1-NED, based by now only on data on DFS and since a few days also on the data on overall survival. In Italy, we have pembrolizumab approved only since July 2023, only in the M1-NED population by now. This is the only trial that that it is ongoing, but no more recruiting patients in the adjuvant setting, which is the LightSpark 022 trial, which basically enroll all the patients with the same eligibility criteria as Keynote 564, and patients are randomized to receive belzutifan plus pembrolizumab or pembrolizumab plus placebo. Primary endpoint is disease-free survival. So let's move now to metastatic disease. We all know from the main guidelines that as a first-line treatment, patients must receive, if they are fit for them, a combination of IO and TKI in all risk categories, or a combination of IO-IO in intermediate and poor risk patients. In this scenario, some new drugs are currently investigated, in particular in the Stellar 306. It's a phase 2-3 randomized open-label study that evaluates the new compound zanzalintinib, which is a novel oral multi-targeted TKI, in combination with nivolumab, relatlimab fixed dose. In particular, relatlimab is an intravenous new monoclonal antibody that demonstrates great efficacy in melanoma and that binds like TRE, inhibiting its signal pathway. So eligible patient must have an advanced or metastatic renal cell carcinoma with a clear cell component. They must have not received prior systemic therapy for metastatic disease, and they must have an intermediate or poor risk per IMDC criteria. And of course, they must have a good performance status. There's the design of a study with a phase 2 and a phase 3 part, and all patients are randomized 1-to-1 to receive zanzalintinib plus fixed dose nivolumab relatlimab or the standard control arm with nivolumab and cabozantinib. All patients will be treated until RECIST 1-1 defined progression or unacceptable toxicity. And the treatment with the immune checkpoints, both nivolumab alone or nivolumab relatlimab, will not exceed 2 years of treatment. Primary endpoint is the progression-free survival. Now, another trial which is not currently recruiting in our hospital is the LightSpark 012, which is an open-label randomized phase 2 study that evaluates efficacy and safety of 2 types of triplets. In particular, in the first arm, there is the quavonlimab, which is an anti-CTLA-4, plus pembrolizumab plus lenvatinib. Second arm, there's the triplet of belzutifan, pembrolizumab, and lenvatinib, and then the control arm with pembrolizumab and lenvatinib. All patients will be again treated until progression disease or unacceptable toxicity, and the pembrolizumab and quavonlimab will be administered for a maximum of 2 years. Primary endpoint is progression-free survival. Now moving to further lines, there's LightSpark 024, which is a multi-center open-label randomized phase 1-2 study of belzutifan with palbociclib versus belzutifan monotherapy. So patients must have an unresectable stage 4 RCC with clear cell component. They must have received 2 or more prior systemic regimens, including at least one PD-1 or VEGF target TKI. So in the part 1, phase 1 of the study, the patient will receive belzutifan plus different doses of palbociclib until the identification of the dose-limiting toxicity. After that, there's the part 2 trial, which randomizes patients to receive belzutifan and palbociclib or belzutifan alone. Palbociclib is a drug that we don't often see in the renal cell carcinoma. In fact, it is very famous as a treatment of locally advanced or metastatic breast cancer, and it is a cyclin-dependent kinase 4 and 6 inhibitor. There are some in vitro evidences that demonstrate a palbociclib inhibition of cell growth in RCC cell lines, and also demonstrate a certain synergistic activity with the HIF2 alpha block mediated by belzutifan. So it could be a potentially new drug interesting to be evaluated. Finally, in the clear cell setting, there's the LightSpark 011, which is a trial that randomizes patients to receive belzutifan and lenvatinib versus cabozantinib. Patients must have an advanced or metastatic clear cell renal cell carcinoma. They must have progressed after a first or second line with anti-PD-1 or anti-PD-L1 therapy, immediately after the immune checkpoint therapy. And patient must have received a maximum of 2 prior systemic therapy. Primary endpoints are PFS and OS. Now, from the clear cell renal cell carcinoma, let's move to the non-clear cell renal cell carcinoma. In particular, just a few words on papillary renal cell carcinoma, which we know it's the second most common subtype of renal cell carcinoma, accounting more or less for 10–50% of cases. Due to its rarity, there are some robust data, and so there's the need of more clinical trials in these kind of patients. The most relevant thing is that approximately 40% of tumors are MET-driven, so this is a potential target for treatment to be evaluated. In particular, it's active and out recruiting the SAMETA trial, which is a phase 3 open-label randomized 3-arm multi-center study for patients with MET-driven, unresectable, and locally advanced or metastatic papillary renal cell carcinoma. So eligible patients must have an histologically confirmed unresectable and locally advanced or metastatic papillary renal cell carcinoma, and this diagnosis must be centrally confirmed as MET-driven by an NGS assay. So there's the first part of the study that consists in this particular screening phase. After the obtaining of all the eligibility criteria, patients are randomized 2-to-1-1 to receive in the first arm the combination of savolitinib plus durvalumab, second arm sunitinib alone, third arm durvalumab immunotherapy. Remaining on the metastatic non-clear cell renal cell carcinoma, there's the STELLAR 304, which is a randomized open-label phase 3 study of zanzalintinib plus nivolumab versus sunitinib in patients with advanced or metastatic non-clear cell renal cell carcinoma. The histologic subtypes that are allowed in this trial are papillary, unclassified, and translocation associated. Sarcomatoid features are allowed, but chromophobe, renal medullary, or pew-collecting duct are excluded. And patient must have not received any prior systemic therapy. All patients will be treated until progression or unacceptable toxicity, and treatment with nivolumab may not exceed 2 years from cycle 1. Primary endpoints are PFS and ORR. So this is the current scenario of trials active or that will be activated in our center. And this is our purpose for a new potential trial, which is the DESTINY RCC, the escalating therapy in complete responders, and the role of therapy rechallenge in metastatic clear cell renal cell carcinoma. This study is born to try to answer to the question of when we can stop with the first-line treatment in patients who are good responders. So eligible patients must have a predominant clear cell histology, they must have a stage 4 renal cell carcinoma, and no prior systemic therapy are allowed. Patients will be stratified also between patients who have received or not a cytoreductive nephrectomy. So first-line therapy will be choice between one of the IO-TKI combination which are available now. Patients will be treated for at least 1 year of therapy, and patients will achieve a complete response or a partial response of over 80% will be randomized 1-to-1 to continue the therapy or stop the treatment. In the RMA, which stop the therapy, if there is a relapse of disease later than 6 months from the interruption, patient will be again randomized to a rescue IO-TKI therapy or to a second-line TKI therapy. This is a non-inferiority design tested at randomization 1, and primary endpoint is the PFS rate since R1. So in conclusion, as also we were saying before, a special thank you is needed to our incredible site staff, because without them, none of this study would be possible. So these are our research nurses and clinical study coordinators. So please give an applause to them, and thank you.
So good evening, everyone. Thanks, Professor. I'm going to talk to you about rare GU cancer. And when I say rare GU, I intend mostly adrenal cancer, renal cell carcinoma excluding clear cell carcinoma, neuroendocrine prostate cancer, testicular and penile cancer. Of course, thanks to Dr. Spies, all of you already know the problems with dealing with rare GU cancer. That means mostly low evidence, low incidence, and a global difficulty with treatment for the patient, for the physician, and for the researcher. So what do we have here in San Raffaele Hospital? The first trial at our disposal is MK-015. It uses a drug you already know, belzutifan. It is an HIF inhibitor, and it is already approved by FDA for uses for VHL-associated renal cell carcinoma. Here, the cohort at our disposal deals with metastatic paraganglioma or pheochromocytoma in patients who already used their standard therapies, which our primary endpoint here is the overall response rate. The next study is the MK-365. This is a study for metastatic castration-resistant prostate cancer, but not adenocarcinoma, neuroendocrine carcinoma. Here we are dealing both with de novo metastatic neuroendocrine or treatment emergent. And when I say treatment emergent, I intend a tumor that had neuroendocrine shift after therapy, both chemotherapy or hormonal therapies. In this case, the histology must be reviewed centrally, so a biopsy is necessary. The patient has to be treated at least in the metastatic hormonal setting with chemotherapy or a novel agent. And the study treatment is the association of pembrolizumab with the standard therapy, which is carboplatin and etoposide, while the control arm is carboplatin etoposide. Let's see the four. This one is a study, actually a basket study, dealing with tumor which had BRAF gene fusion. The study drug is the plixorafenib, and we already know most of the BRAF inhibitors at our disposal mostly focus on mutation of the 600 BRAF. Plixorafenib is innovative because it is capable of inhibition of BRAF gene fusions. Patient must receive the standard therapy, and we can enroll especially patients with prostate carcinoma, but the caveat here is they must not express the androgen receptor splice variant 7 because that will render the disease resistant to plixorafenib. Our primary endpoint here is overall response rate, and plixorafenib has to be associated with cobicistat, which is a normal cytochrome inhibitor. And the last one is XL092, which focuses on zanzalintinib. We already talked about zanzalintinib. In this cohort, we focus mostly on rare renal cancer, especially metastatic papillary, unclassified and translocation associated. And the study treatment here is associated with nivolumab, nivolumab ipilimumab, or nivolumab and relatlimab. This is a phase 1, phase 2 study. That means that our primary endpoints are mostly safety and overall response rate. Just a quick proposal for you. We already know that TROP2 can be an interesting target for our studies. We know that it is expressed variously in several different kinds of GU tumor. If we focus only on rare kind of cancer, we know that its expression is mostly in papillary renal cell carcinoma, small cell neuroendocrine of the prostate, and squamous cell carcinoma of the penis, which can have a strong expression. We also know that we can detect TROP2 amplification on blood, but we don't have a clinical correlation to that. Moreover, in this kind of cancer, we know immunotherapy has some kind of activity, but we don't know its effectiveness nor the best way to use it. So my simple proposal is, if you take the patient with cancer who express TROP2, especially metastatic papillary renal cancer, prostate neuroendocrine, and penile squamous cell carcinoma, after the first-line therapy, we can randomize them to sacituzumab or sacituzumab plus pembrolizumab, with our endpoint being overall response rate and safety. So we can assess if this therapy can have some kind of activity in this setting, and if we perform liquid biopsies at some time points, means evaluation with CT scan, we can also assess if TROP2 can have some kind of prognostic or predictive factor, since we know that especially in papillary renal cancer, there can be some kind of prognostic effect, while in other kind of cancer, namely triple-negative breast cancer, we know there is an effectiveness of sacituzumab regardless of the expression of TROP2, while patients who had a higher expression had a higher benefit. Since to me, a study is simple and quite feasible. And we already talked about the Global Society of Rare Genitourinary Tumors, and I therefore thank you for being here at 6 p.m.
Thank you, Damiano. For the first time, the GU Retreat Award, Abstract Award. And this year, actually, we launched this call for abstract, in particular related, is anyone helping me here? Related to the topic of promoting equitable and sustainable development in GU oncology. Thank you. So we receive a lot of abstract, so I will show you very briefly the outcomes and the selection of the winner, if I may move somewhere. Non so se l'hanno nominato, non su, né chi abstract. The jury was composed by young guys, smart guys, I would tell, 6, 7 guys, right? You should know at least a few of them, and they made a scoring of each abstract from 0, very low, bad abstract, to pushing the rubbish, and 5, very high, outstanding, plenary session at ESMO. Panel members abstain, of course, if they have conflicts, some involvement in the co-authorship of abstract, of course. And the criteria for the evaluation of the abstract were very, very open, very easy. Overall quality, novelty, impact on findings, and most importantly, adherence to the topic. We received 15 abstracts. I would say that the average quality was quite good. But the majority of the abstracts were very much penalized by the fact that they were not completely out of the topic, actually, of the call. So this is not a judgment based on the quality of the abstract that was quite good, quite high, but principally that were out of topic and they were penalized consequently. So the winner abstract is abstract by Valentina Tateo, who is our Champions League winner, right? She submitted an abstract on the role of androgen response pathway association with tumor biology and response to immune therapy in PURE1. So, Valentina, you have a very tight timeline, 6 minutes to present your findings and to convince us that our choice was good, that their choice was good. Otherwise, we may change our mind. Please come here. and present your abstract. 6 minutes or more.
So I'm here again. Thank
5
you
minutes
for,
left.
5, okay. So thank you for this great opportunity, and let's start immediately. There are rising evidences of important difference between males and females in several aspects of cancer, starting from cancer biology, but also immune system and behavioral and environmental factors. All those factors could influence the response to immune checkpoint inhibitors between males and females. This is a topic of discussion in the scientific community, since there are opposite data published. This is the first meta-analysis which showed difference in benefit from immune checkpoint inhibitors between men and women, with a great benefit for males. And this is the other meta-analysis which denied the conclusion of the previous meta-analysis, showing no differences in immune checkpoint inhibitor benefit between men and women. So the role of sex in influencing the response to immune checkpoint inhibitors is still debated and unclear. Anyway, a role of hormones and of androgen receptor in the carcinogenesis, development, and resistance to therapy in cancers, also not hormone-dependent cancer, was demonstrated. Androgen receptor was encoded in the X chromosome and is composed by 3 principal domains. The androgen receptor, when activated by the binding of androgens, migrates from the cytoplasm to the nucleus, where it binds the androgen response elements, inducing the transcription of genes involved in the androgen response pathway. Also, other non-canonical, non-genomic pathways are reported, with several targets, pathway targets involved. The androgen receptor pathway was investigated also in urothelial carcinoma. The gender-specific differences in the incidence of bladder cancer and the presence of androgen receptor expression in urothelial are important clues of a critical role of androgen-mediated signal in bladder carcinogenesis, and also androgen receptor pathway has a role in vision and metastasization of urothelial carcinoma through different pathways. Based on these evidences, we perform a retrospective analysis of the role of androgen receptor pathway in patients treated in the PURE-01 trial. The PURE-01 trial is a neoadjuvant trial of pembrolizumab followed by cystectomy, and the last results published after 3-year median follow-up reveal a 3-year event-free survival of 74%, a 3-year overall survival of 84%, and a pathologic complete response rate of 42%. So we perform a retrospective evaluation of sample from baseline transurethral resection of the bladder in patients treated in the PURE-01 trial. A transcriptome-wide expression profiling was performed, with a focus on androgen receptor gene expression and on the expression of 117 different genes related to the androgen response pathway, the so-called hallmark androgen response signature. Subgroup comparison was performed using the chi-square test and the Wilcoxon-Rank sum test, and Kaplan-Meier method with long-run test was used to evaluate event-free survival. These are the cohort characteristics, and these are the results. So no differences between male and females were observed for androgen receptor gene expression and signature score, androgen response signature score. But an important consideration is about the population composition for gender, with the female population underrepresented in this trial. A significant higher expression of androgen receptor gene was observed in luminal tumors with respect to other molecular subtypes, but this is true only in the TCGA molecular classification. While a significant higher level of androgen response signature score was observed in luminal tumors with respect to other molecular subtypes in all the three principal molecular classifications. Complete response, low level of signature, of androgen response signature correlates with complete response, while no association was observed between complete response and androgen receptor gene expression level. Patients with tumor with low level of androgen response signature scores presented a longer event-free survival with respect to patients with a high level of signature score. No significant differences were observed for overall survival. So, in conclusion, males and females present dimorphism in immune system, cancer biology, environmental factor, which could influence response to immune checkpoint inhibitors. The real impact of sex on immune checkpoint inhibitor benefit is still unclear and debated. Androgen receptor pathway seems to influence tumor development, progression, and resistance to therapy, also in urothelial carcinoma. The results from this retrospective analysis show that androgen response signature could be a negative predictive biomarker of immune checkpoint inhibitor benefit, with low signature score associated with complete response and longer event-free survival in patients treated with pembrolizumab and then radical cystectomy. The androgen response signature is more expressed in luminal tumors in all the three molecular classifications. The same is true for androgen receptor gene expression, but only in the TCGA molecular classification. So finally, androgen response signature should be validated in larger studies as biomarker of immune checkpoint inhibitor benefit, but it also should be considered as possible therapeutic target, maybe in combination with immune checkpoint inhibitors. So we are different but equal, and thank you for your attention.
I think we have to close the door because otherwise they close the door for us. So it's better to close the door as soon as possible. Thank you again for coming here. Thank you again for attending. It was a special prize from you to myself. I really appreciate it. So thank you very much again. Enjoy the rest of your time here in Milan. Thank you very much. See you next year.